Hi there, good afternoon. Thank you so much for having me. I really want to extend my sincere thanks to Dr. Madura, Dr. Bowers, and Dr. Trudy. It's a real pleasure to come and speak to a surgical audience, and you heard a lot about endoscopic therapy, so I think given the obesity epidemic, I think we are going to need an all-hands-on-deck approach, and there's a lot of innovation happening in this space, so I think we have some exciting things to look forward to. And I think a lot of innovation is also happening in the management of the post-bariatric adverse events, as some of it has been alluded to, and I'll sort of give you an endoscopist perspective on this. So this is sort of the outline of my talk. I won't go into a lot of detail about numbers and things like that. This has been presented, but mainly we'll talk about marginal ulcers, gastrojejunal strictures, the outlet reduction procedure that Dr. Ellie sort of mentioned, and our approach, sort of what are the best lessons we have learned from managing sleeve stenosis, leaks, fistulae, and I'll just touch upon ERCP in the post-Roux-en-Y anatomy, if you collaborate with endoscopists, what the options are. So I'll go through this, the number of operations that are increasing. There is a growth rate for bariatric surgeries. So as with any operation, any intervention, there are issues. Again, the previous speakers have touched upon these. I think the landscape is changing, especially in Asia when we travel, especially in India and other places. The one anastomosis bypass is really taking off. So I think it's important to understand anatomy, and some of you may be doing endoscopy. I thought it would be, I always start an endoscopic bariatric therapy talk, at least for GI, with saying that we need to really understand the anatomy. And I think going back to this, understanding what the operation is, going back to the operative note, I think is very, very critical. As with any procedures, you know this better than I, the bariatric surgeries do have adverse events, and a lot of these can be managed. I think the sleeve, the leaks, and the stenosis are ones where we can be quite helpful, so it's something to think about in your practice if you do these. So just as I was mentioning, I think one needs to understand when we do an endoscopy what we're looking at, and also for us to be able to report effectively so that when you get that report, you know that we've done a good assessment of the anatomy. So if I was doing